Hello, everyone. My name is Bharti Khurana, and I'm an emergency radiologist at Brigham and Women's Hospital. It's an honor and a privilege to present my work on intimate partner violence. Here is my funding information and some non-relevant financial disclosures. So imagine if one place where you're supposed to feel the safest, your home, is actually the most dangerous. For millions of women in every corner of the world, this is a reality. According to the United Nations, the most dangerous place for a woman is her own home, because more than 50% of all female homicides in the US alone are linked to intimate partner violence, or IPV, which is physical, sexual, or emotional violence between current or former partners. Now, one of the biggest misconceptions about IPV is that it affects only a small part of the population. The truth is that 1 in 4 women have reported experiencing physical violence by an intimate partner during their lifetime. It is also a misconception that people who are financially independent or well-educated don't experience IPV. The reality is that abuse happens to people from all types of families, income, education levels, ethnicities, religions, and professions. Even my own physician colleagues at the Brigham have experienced IPV. No one is immune. It's a worldwide crisis that we saw worsen during the height of COVID and continues to be pushed into the shadows with the prevalence of remote work. Here is an article from NEJM just before COVID that motivated me to explore this topic further. This is a pediatric emergency medicine physician sharing her life story, lying about her injuries and how her calcaneal fracture actually became a turning point for her. Not because she got the fracture, but more importantly, she realized that she could no longer run away to breathe next time she gets strangled by her husband. So I'll take you to my reading room. Here is a 38-year-old woman hit and strangled by her husband. We see a fractured humerus. As I was reading our study, an old X-ray popped up on my screen as a comparison. This is again a fractured humerus, but of the other side, and it's from 13 years ago when she was 25. At that time, she reported history of fall, but we know this fracture is oblique, which is often due to violent pulling and has some healing already. So that means she presented to us quite late. In between, she had 68 radiological studies on my PACS. This was a woman who at 25 was healthy, young, and active with her entire life ahead of her, but would instead go on to suffer 13 years of abuse. What would her life have been like if we caught this at 25? How much pain, physical and mental, could we have prevented for this woman? How can we help millions of other women avoid the same fate? So we diagnosed her fracture in 2005, but missed her real diagnosis of intimate partner violence. Now, victims seek medical care and feel more comfortable sharing their personal stories with healthcare providers than law agencies. It is for this reason we screen these patients. But the screening questions are simply based on self-reporting. Here is the patient and provider journey with the current screening tool. Both patients and providers might not recognize the problem initially. So this is like inactive problem recognition. We are not trained as providers. We are not trained to identify intimate partner violence. The patient often minimizes the issue. They go through feelings of denial, self-blame, justification, thinking that it really doesn't happen every day. It just happens only when there is stress, only when children are doing something else, or if he drinks, or there's always some justification. By the time the patient starts recognizing the issue, there are concerns about social stigma, dependency, isolation, safety of children. And even as providers, we are understanding, but there's always that fear of offending the patient or the spouse because we don't have any objective evidence, and there are time constraints and in general, like some misconceptions, some stereotypes we have. And as a result, when they disclose, it's actually too late. By that time, there are already long-term adverse health effects. There are homicides, suicides, it has become intergenerational. And, we go through regret and frustration. So, still 80% of IPV cases come through ED, but only 5 to 30% are flagged. And if you are thinking that this is a private issue, let me share, your tax dollars are providing shelter, state aid, legal aid to these patients. And in the US, every year, 2/3 of mass shootings have been linked to intimate partner violence. So there are many papers in the literature talking about barriers for healthcare providers. Here is a survey in the orthopedic literature, an ortho resident responding to the survey, that he has never asked one question because he has never seen his attendings asking such questions. And what am I doing as a radiologist? So this poster came out 30 years ago. We all know that we see the signs of abuse on radiological studies. The technology has advanced, and now I can make 3D deformations to show these depressed fractures as this victim was beaten with a hammer. But nothing else has changed. We diagnose these injuries, but often forget the person. So I tried to explore if a radiologist can identify or diagnose intimate partner violence. In the beginning, none of my colleagues got interested. So I just reached out to our first, second, and third year residents. And it took 2 years for us to do the case, to do this study. This was a case control study with 185 patients reporting IPV, with age and gender match control patients not reporting IPV. Now we looked at the radiological reports 5 years prior to their self-reporting. So 5 years before the patient disclosed IPV. We saw a lot more radiological studies with more OBGYN findings, more acute fractures involving face and skull, and more chronic fractures involving extremities and nose in patients reporting IPV compared to control patients. Now let's try to understand this better. Now the target area is the face. The victim is pushed to the wall. So we will see injuries of the face and the shoulder. And there are defensive fractures, often involving hand or forearm. And all these can happen at the same time or on different locations, but they leave evidence or stigmata on radiological studies. So this led us to believe the power in radiology and AI to detect IPV. So by recognizing high imaging utilization, location, and imaging patterns specific to IPV, old injuries of different body parts, and injuries inconsistent to the history, one can make an objective, unbiased report. So this is how we have always reported these injuries. But now we have started to put things together to make the diagnosis in terms of target and defensive injuries. So this woman is raising her forearm to protect her face, and she will get injured at both places today or next time. So I looked at the prior literature, compiled these injuries at target and defensive into a radiographics paper, and I thought I was done. And as I was showing the significance of ulnar fracture, so ulnar fracture is considered a defensive fracture. So I was showing that how ulna gets exposed, when somebody's raising forearm to protect the face. And this is different from more commonly sustained radial fracture, which occurs because of fallen outstretched hand. So it is not easy to break ulna due to fallen outstretched hand because the force often goes through the radius rather than ulna. So as I was explaining this, I remember the media person asked me if I raise suspicion anytime I see isolated ulnar fracture for intimate partner violence. And I was speechless. And I asked the orthopedic surgeons too, and none of us were following that. So we decided to do an exploratory study. So this was a multidisciplinary study, and we had two simple questions. Does an isolated ulnar fracture in a woman represent IPV? And can we differentiate an ulnar fracture due to IPV from accidental causes? So we reviewed EMR of women with isolated ulnar fractures from 3 level 1 trauma centers and found that 26% of isolated ulnar fractures in women were attributable to IPV, and almost 1/3 of women with isolated ulnar fractures were either confirmed or clinically suspected to have IPV. Interestingly, we developed an objective criteria using guidelines from the Orthopedic Trauma Association to record morphological features and found that IPV fractures are more commonly often non-displaced, transverse, non-comminuted, and more in mid to distal ulnar shaft, unlike MBA, where the fractures are proximal, comminuted, and displaced. Here are some examples. And so we learned this from our social workers and patients that these fractures are often non-displaced due to the fact that their wrists are held very tightly, and ulna being a weaker bone often fractures. So mid to distal ulna, non-comminuted and non-displaced. Now, in the interest of time, I will just quickly review different body parts. Continuing with the upper extremity, the most common upper extremity fracture was finger fracture, often medial 4th or 5th finger fracture, non-comminuted and non-displaced. Now, you really have to magnify these x-rays to look for these fractures because they can be very subtle. Now, our surgeons were not happy with the results. They wanted more evidence. They cannot suspect all finger fractures due to IPV. So we analyzed the national database, and they were right. Accidental striking was the most common cause for finger fractures, but it was less likely to have a finger fracture due to fall. And so therefore, pay attention to the injuries which are inconsistent to the history provided. Now, going to the face, mid-face is the most common area. It's the target. So in our series, fractures were more common in mid-face. And so the nasal bone fracture was the most common, seen in 1/3 of all facial fractures. And again, with the same theme, no displacement, more common to have associated upper extremity injuries, and there were recurrent facial injuries as well. And as because of right hand dominance, we saw more left-sided injuries. So here are some examples. So this is a 21-year-old woman with recurrent facial injuries. So you can see the blowout medial orbital wall fractures and extensive soft tissue edema. She also had this defensive fracture, an oblique fracture of the proximal phalanx of the ring finger. Now, 1 year later, she presented again with recurrent facial injury, with left nasal bone injury, and she had periorbital soft tissue swelling, but she also had stigmata of prior injury. Here's another patient, 32-year-old woman with a history of assault. So we see nasal bone fracture, and then later on she had another injury. So she had periorbital soft tissue swelling and a foreign body. This was a glass piece in her soft tissues and a acromioclavicular joint injury. Now coming to the chest. So unlike non-accidental trauma in children, where we see bilateral posterior rib fractures, we found that right lower anterior rib fractures were more common in these patients, most likely as these patients get kicked in their abdomen when they're pushed down to the floor. So right lower anterior ribs, non-displaced, associated facial and upper extremity injuries were common. So here are two different patients. So this patient has classic right anterior lower rib fracture, and this was a stab injury. So usually penetrating injuries or stab injuries, history is usually not withheld. We also identified an unusual pattern of fractures in the lower extremities. Initially, my team of 4 emergency radiology fellows and I were definitely puzzled by the high incidence of forefoot fractures. But deeper understanding emerged during our multidisciplinary conferences. So patients were sustaining these injuries due to their spouses often stepping on their feet as a form of punishment for making comments unacceptable in public settings. So actually, forefoot was the target. And we were, if you're seeing hindfoot injuries, so for example, the calcaneal fracture I showed in that woman, the NEJM article where that pediatric emergency medicine physician just sustained calcaneal fracture as she was trying to run away. So we do see those defensive fractures as well. So these forefoot fractures are again non-displaced and non-comminuted. So looking at the head injuries, so these patients had lots and lots of head CTs, but 94% of head CTs were negative. And it makes sense because often these are recurrent mild traumatic brain injuries. So they are symptomatic. They have cognition issues, unfortunately, but we are unable to see those injuries on CT head unless we do advanced MR imaging. But frontal soft tissue swelling is often the prefrontal area, and then again, left-sided injuries. And often these patients have other injuries as well. So pay attention to imaging utilization. So now we are able to show structural connectivity disorder in these patients, leading to severe cognition issues. This is the case I showed earlier, and we really don't want to wait until this happens. It is too late. We want to diagnose it early. What else you can look at? So we talked about target and defensive injury patterns, that combination. We can also look at acute and chronic injuries. So these are the patterns you can definitely look at to make the diagnosis. Now, quickly, I want to talk about COVID because as we were trying to understand and recognize these patterns during COVID, suddenly we noticed that the patterns changed. We started seeing really severe injuries. So we compared COVID 7 weeks, early COVID, compared to 3 years, and we noticed that severe and very severe injuries increased, and also there were more thoracic and abdominal, more stab injuries compared to 3 years ago. So when we are seeing severe injuries, so remember, severe injuries indicate only the tip of the iceberg. So that means there were a lot more injuries happening, but we were seeing only the most severe injuries because of patients not coming to the ED for milder injuries. And our role as radiologists has become a lot more important now with all these virtual visits where screening questions are skipped and there are no visual cues. So they are not able to see. So our physicians are unable to see those incidental bruises as they were seeing in the past. So with our own paper, we also noticed that radiologists were able to predict IPV status confidently by reviewing historical reports only. So for example, in this case, this patient with ulnar fracture had lateral malleolar fracture 4 months ago and a foot fracture 2 months before that. So their sensitivity was pretty high. So they were blinded to the status of IPV and they had to predict IPV status. And these numbers were definitely encouraging us to build an AI model. So I also did the study with our 4 emergency radiology fellows. So their prediction rate was 47% in patients reporting physical abuse. So this number was definitely not encouraging. However, they could diagnose IPV by a median of 69 months before the patient self-reports in more than 50% of patients. So that was definitely encouraging. But we all know that we have no time to access and review all historical data. I start feeling guilty if I'm spending more than a minute on wrist X-ray. There are silos of subspecialized radiology. So I don't expect a neuroradiologist to look at the wrist X-ray and vice versa. There is cognitive overload. There's so much we can synthesize. And in general, we are always trying to address the most urgent issue. And this is the reason we had to bring AI. So we know we have to make this automated. So this was our first attempt using radiology reports alone. And it came with 95% sensitivity and 64% specificity, allowing us to diagnose IPV with a median of 2 to 3 years before patient self-reports. So this wasn't enough. We knew that we had to bring non-imaging indicators or metadata available on images. So one is definitely imaging utilization. So we know that the frequency of injuries is more important than severity of injuries when you're predicting IPV. And our studies showed that, our patients had a lot more injuries, so almost 4 times more. So pay attention to the imaging utilization. The other thing is where these injuries are occurring or where this imaging is occurring. So ED imaging is definitely higher in these patients, so disproportionate ED imaging. Similarly, we looked at the temporal patterns. So depending on time of the year, week versus weekend, and day versus night. And obviously, we don't expect radiologists to look at the time for previous study, but we can include this in our algorithm. So IPV peaked, so we can peak late Saturday or early Sunday in the spring and winter, correlated with IPV. Similarly, holiday effect, IPV peaks during New Year's Eve, July 4th, Labor Day, and Christmas. And we expected differences in injury patterns as abuser becomes older and experienced with grown-up children. So we found that the trunk fractures were a lot more common in older patients, and there are fewer, still the most common injury for sure, but there are fewer head and neck injuries compared to younger patients. And there were more hospitalization, but the most concerning part was that 1/3 of our older adult victims were men. So that led me to look at the intimate partner violence in male patients, and there were a lot more lacerations, more injuries, more hospitalization, because there's a huge stigma among men, for reporting intimate partner violence. So then I also looked at another segment of the population, so more teen. So teen IPV is significantly underreported, as often teens might accept this as part of a relationship and may not share it with their family and friends. Definitely correlating more with sexual assault and lower trunk, and most importantly, something we are noticing for last few years, issues with sexual asphyxiation. So we looked at the specifically for assault-related anoxia. So we couldn't really find much on strangulation, but we noticed that using national database again, IPV accounted for 40% of assault-related anoxia, almost 1/3 of contusions, and 20% of neck injuries, even though it constituted only 11% of assault-related injuries. Now, we also did we tried to build this risk prediction model for pregnancy, IPV during pregnancy. And this is where we noticed that we had to bring radiology, non-imaging, and also clinical indicators. So here's a solution. It's called AIRS, Automated Intimate Partner Violence Risk Support. It is a risk stratification model built on historical imaging and clinical data that quantifies risk probability for every patient and demonstrates patient-level IPV predictors. And it also comes with caring conversations. And it uses HIME, so Holistic AI in Medicine, developed by my co-investigator and former professor at MIT. And this tool is allowing us to diagnose or, create or at least raise concern for IPV 6.5 years before patient self-reports. So we know that 1 in 4 US women experience IPV in their lifetime, meaning this tool has the potential to impact more than 40 million in the US alone. And until we complete this tool, I want you to keep looking for target and defensive patterns and raising your concerns about potential IPV. We are not recommending putting in the report, as I learned from our social workers and advocates, that we have controlling spouses who look at the reports before even patients get contacted. And as this tool is implemented in emergency departments, primary care offices, clinics, and often healthcare and other healthcare settings throughout the world, we will work together to make home a safe place for women the way it should be. Thank you for your attention.